Starting from where we left last time, guys, because there was some problem in the video. So coming to the lab diagnosis in CML, as we talked that all the cells are coming out in the peripheral blood here. So all the series of cells will be coming out. So if you look at the maturation phases of WBC, so if I go to this picture which I showed you in the last video also, so whenever we're looking at the precursors of the WBC, remember the code PMMS, that is promyelocyte, okay, myelocyte, metamyelocyte, and stab. And this further give rise to neutrophils, eosinophils, and basophils. So because bone marrow is producing so many cells in CML, all these cells will be pushed out in the peripheral blood. So there will be more promyelocytes, myelocytes, metamyelocytes, stabs, neutrophilia, eosinophilia, and basophilia. So if you look at them, how to identify? Remember the nucleus shape is what tells you the answer. Remember the code O, D, B, and C. Okay, O-shaped nucleus is promyelocyte, D-shaped nucleus is myelocyte, okay, B-shaped nucleus is metamyelocyte, and C-shaped nucleus is stab. Okay, neutrophil, has 3 to 5 lobes. Eosinophils is spectacle shaped, okay, with lot of red color granules. Basophil has coarse granules, so you can't even see their lobes. Okay, so once we are clear with this, look at this cell. Okay, everybody, can you see this D-shaped cell here? So this is a myelocyte, which you can see. Can everybody focus on this B-shaped cell here? This is basically your metamyelocyte. Okay, so these are your metamyelocyte. Can you see the cell again? This is a B-shaped cell, metamyelocyte. Just near this B-shaped cell, can you see the cell with coarse granules that you can't even make out the granules? That is a basophil here. Okay, apart from that, again you can see a D-shaped cell here. This is a myelocyte. So you can see all the types of cell, and can you see this is a neutrophil? So there'll be neutrophilia, eosinophilia, basophilia, and shift to left. All these cells are there. So this appearance is called as a garden party appearance. Like when you go to garden party, what do? You wear different dresses and go, isn't it? So it's like you're wearing different dresses and you're going into the peripheral blood. Okay, and you're going into the peripheral blood. So there are various types of cells in the peripheral blood, and whenever they give you exam picture like this is your CML. Okay, remember that point. Okay, so one of the typical questions, okay, so whenever the typical question of the CML, first you have to remember, so how to make a lab diagnosis of CML. Lab diagnosis of CML can itself be asked as a question. So remember, first thing that is going to help you is complete blood count. So if you do complete blood count, you will see that the WBC count is very high, your platelet count is very high. Okay, and if you look at the patient's count, there will be neutrophilia, eosinophilia, and basophilia. All the three will be increased. Now, if you go to the peripheral smear examination, all of you know just now we have talked about this is a garden party appearance, and you will see O, D, B, C. Okay, that is promyelocyte, myelocyte, metamyelocyte, and stab. Along with that, you will see neutrophilia, eosinophilia, and basophilia in the peripheral blood. Okay, so that will be finding in the peripheral blood. Now, once we have done the morphology, from the last videos, we have to always discuss the lab diagnosis in 3 headings: CBC and morphology, special stain, if any, and diagnosis of choice. So these are the 3 headings in which we should always answer. Okay, so what is a special stain here? So there is a special stain which is called as NAP. This is also called as lab. What is this? Neutrophil alkaline phosphatase or leukocyte alkaline phosphatase. The cell of origin of CML is stem cell. So if the mutation occurs at the stem cell, all the cells below this are malignant cells. Now, alkaline phosphatase is one of the components of the secondary granules of the neutrophil. So if the mutation is in the stem cell level itself, secondary granules will not be formed properly. So what will happen to the NAP? It will be low. Okay, so NAP will be low in cases of CML. It is an alkaline phosphatase. So you can say it as a leukocyte alkaline phosphatase or neutrophil alkaline phosphatase. It will be low. Now, next question, can lab be increased in CML? Yes, if the patient is having infections or the patient is going into blast crisis. These are the 2 conditions in which the NAP can be increased. Now, here is the question that they are asking you basically. So, whenever you see so much shift to the left, sometimes it has to be differentiated from leukemoid reaction. So they can ask you, how do you differentiate CML from leukemoid reaction? So first thing you have to write in that in leukemoid reaction, usually basophilia will not be there. Okay, so basophilia, if you say, is usually a feature of CML. That's first point. Second, if you do a special stain, you will see on the special stain, NAP count is low in CML, whereas leukemoid reaction is just a response to some infection. So basically, a lot of neutrophils will be formed, and these neutrophils are normal neutrophils, so they will have lots of alkaline phosphatase. So alkaline phosphatase will be increased in leukemoid reactions. Okay, so that's the point that you have to remember in cases of CML and how it is differentiated from leukemoid. Do mention that point so that examiner is happy that yes, he knows it. Okay, now coming to the diagnosis of choice, see documentation. Diagnosis of choice is always by documentation of mutation. So what was the mutation? That is 922 translocation, which leads to formation of Philadelphia chromosome. So you have to document presence of Philadelphia chromosome. And how do you document Philadelphia chromosome? This can be done either by FISH or by PCR. Okay, so if somebody asks you which is better, okay, so both have their own advantages and disadvantages, but the advantage of PCR is that you can use it for follow-up of this patient. Okay, now let's look at this technique here. You can remember whenever they are giving you an exam, draw lots and lots of diagrams. So you've drawn already the Philadelphia chromosome diagram, write the draw the morphology of CML, which we have talked about. Okay, then draw the diagnosis of choice. That is usually FISH. So if you look at this, what is FISH? By the way, fluorescent in situ hybridization. Fluorescent in situ hybridization. If you look at this, green color is basically for BCR. Okay, red color is for ABL. So what happens in CML? BCR comes over ABL, and this gives rise to a yellow color signal. So BCR ABL translocation on the top, that is BCR and ABL on the top of each other. This gives you a yellow signal, and that is what is called as BCR ABL translocation or a Philadelphia chromosome. That is required for the diagnosis, and this is the diagnosis of choice for CML. Okay, right. So that is the diagnosis. So let's come to the headings which we were talking about. Yes, so we have talked about, okay, we have talked about the clinical features. Okay, so we have talked about etiology. Everybody is clear with the mutation here. Pathogenesis, because of this tyrosine kinase is activated, so proliferation is increased. Everybody clear with clinical features, usually presents with splenomegaly. Okay, diagnosis, everybody clear with the morphology, garden party appearance, special stain, NAP, diagnosis of choice, FISH. Now coming to the prognosis and treatment. So you remember the main culprit here in CML is tyrosine kinase. So the mutation is actually increasing the tyrosine kinase activity. So you give tyrosine kinase inhibitor. So the treatment of choice for CML is tyrosine kinase inhibitor, which is usually imatinib. So imatinib is tyrosine kinase inhibitor, which can be used for the diagnosis of CML. So that is what you have to remember in cases of CML. Okay. What about the prognosis? Normally, the prognosis of CML is very good if you treat it with tyrosine kinase inhibitor. But if it is progressing into a blast phase, okay, so CML is normally chronic phase, but it can progress into blast phase if it acquires new mutations. Okay, so if it acquires new mutations, there are additional chromosomal mutations, then it can have a poor prognosis. So poor prognosis can be seen either if there are new mutations in CML or if it doesn't respond to imatinib due to any cause, imatinib resistance is there, okay, or tyrosine kinase domain mutation is there, then there will be poor prognosis, okay. So that is about your CML, which everybody should be very, very clear with. Now, in contrast to CML, the other chronic leukemia was CLL. So again, we'll talk about this. First, let's talk about the etiology. So CLL basically is one of the most common chronic leukemia of West. Okay, so this is very common chronic leukemias of the West, and it is also leukemias of exception. So nearly you have studied in AMLs, ALLs, CML. Most common mutations are translocations. CLL, the most common mutation is deletion. So deletion of chromosome number 13q. So just remember 13. If you remember, that is also enough. Deletion of chromosome 13 is the most common mutation of CLL. Okay. And I told you this is the leukemia of exceptions. So deletion of 13 is the most common. The main pathogenic event in any chronic leukemia was increased proliferation. But in CLL, the main pathogenesis is because there is decreased apoptosis. Okay, so cells don't die. So imagine your world nowadays. Okay, so what is there? There are so many people everywhere. Okay, and you are increasing the life expectancy. So suppose if people stop dying, what is going to happen? They're going to roam like zombies, isn't it? So they'll not die, they'll just roaming like that, like a zombie. That is what happens in CLL. So more than increased proliferation, decreased apoptosis is the problem. So cells don't die. Okay, so this causes persistence of lymphocytes. So what do you see in this smear here? So if you look at this smear, you will see there will be lots and lots of lymphocytes itself. Okay, so there will be a lot of lymphocytes in the peripheral blood. So the absolute lymphocyte count normally, okay, it's approximately 4,000. So in this case it will be more than 5,000. Okay, so there will be persistent lymphocytosis, okay, which will be seen. Now because their proliferation is not much increased, so therefore they are asymptomatic. But these lymphoid cells are not normal, they are abnormal, so they will be fragile and they'll rupture. So these ruptured cells are called smudge cells. What are they called as? Smudge cells. Okay, so therefore, what is the etiology and pathogenesis of CLL? It's a leukemia of exceptions. Deletion of chromosome 13 is the most common mutation, and decreased apoptosis is the main pathogenic event. Because of this there is persistence of lymphocytosis, and the lymphocyte count becomes more than 5,000. So how are you going to make a diagnosis? What are you going to make how are you going to make a lab diagnosis? Let's look at the heading now. Lab diagnosis of CLL. Okay, so lab diagnosis of CLL, again three headings. Is there a what is the morphology and CBC? What is the special test? And what is the diagnosis of choice? These are the three headings, right? So in morphology, let's look at the morphology here. So what do you see? You will see that there are only one type of cells here, that is lymphoid cells. So there are a lot of mature lymphocytes which are there. Okay, so there are only lymphocytes in the peripheral blood, and you can see these ruptured cells here. What are these? These are nothing but smudge cells. So you will be seeing smudge cells. So why are you giving so much importance to smudge cells? More the number of smudge cells, better the prognosis. Okay, better the prognosis. That means you can, if you give the therapy, these cells will die. Okay, so smart cells give you a better prognosis. Okay. Now, once you are clear with this, sometimes what happens is, I told you in the clinical feature also, the majority of the time CLLs are asymptomatic, but because they are lymphoid neoplasm, and sometimes there is overactivity of Bruton tyrosine kinase, which is a very important pathway for switching of the immunoglobulins. Because of this, there are a lot of autoantibodies which are formed. So these patients can sometimes, you can see spherocytes also along with this. So they can present with autoimmune hemolytic anemia. So therefore, in all cases of CLL, we should always check for autoimmune hemolytic anemia. That is one point that you always remember and write down in an exam. You'll get extra point on that. Now, is there any special stain? They are normal mature lymphoid cells, so there's no special stain in this case. Okay, there's no special stain. So morphology, this is called as convent girl appearance. Why this is called as convent girl appearance? Have you seen convent girls? You know, they have, if you look at them, they all look similar because they're wearing same uniforms. Just like that, all these lymphoid cells look similar because they're coming from one clone only. So they all look monoclonal. They are the same clone, just like a robot movie Rajnikant. If you look at him, they were all similar. Just like that, they're all similar. This is called convent girl appearance. And of course, your lymphocyte count has become more than 5,000. And there'll be a lot of smudge cells which you can see. So at least you should write these three findings. And if for extra point, please mention autoimmune hemolytic anemia can be associated, so spherocytes can be seen. On WBC, lymphocyte count will be increased. Rest, everything will be normal. Now, is this special stain? No special stain. And what is the diagnosis of choice, guys? It's flow cytometry. So CLL cells, they are coming from a one clone. So they are usually CD5 and 23 positive. Okay, so there is positivity for CD5 and 23. Always remember, there are B cell CLLs are more common. Okay, so that is why they will be CD19 positive and they'll be positive for CD5 and 23. Okay, that's the diagnosis of choice, flow cytometry. And if you want an extra point, Okay, okay, let's not go into this. Let's not go into extra. These are the enough points for you. Now, coming to the therapy, so and prognosis. So again, the headings. We'll go back to the headings. Where was our headings? Headings, headings. Where were the headings that we had made? Quickly, quickly. Yeah, this one. Okay. Now, once we're clear with this, now we have prognosis and therapy. Okay. So, do we treat all the CLS? So, asymptomatic person coming to you, elderly person, asymptomatic coming to you. Okay, sir, I'm just having very much fatigue. You say, okay, from tomorrow we'll start chemotherapy. No, no. So, for all the CLL, that is why we do staging, and this is called Rye and Binet staging. So Sarai and Binet staging is done for CLL, and this helps in identifying which are high risk CLLs. Okay. So what is the prognostic score for CLL? Just remember, write on one line, Rye and Binet. And of course, therapy. So therapy depends upon whether the so therapy you needn't write. Remember, therapy is dependent upon Rye and Binet scoring. On the basis of that, we decide the therapy protocols. Okay. So that is about CLL that you should all remember. So just to revise, a recap of chronic leukemias, remember, a 60-year-old male presenting with splenomegaly, okay, on the peripheral smear, garden party appearance, on the special stain, NAP is low, and what is the diagnosis of choice? Fish. This is nothing but a case of CML, okay. Let's look at the other spectrum, okay. Again, a 60-year-old male only presenting with fatigue, on peripheral smear, convent girl appearance, no special stain, diagnosis of choice, flow and 5 and 23 positive, diagnosis of this case is CLL. Okay, so I hope you would have understood this and you will be able to identify the garden party appearance and convent girl appearance and you'll be able to answer this question very well.